Now I would like to introduce our speakers. Michael Hasselberg is an associate professor of psychiatry and clinical nursing at the University of Rochester. He founded the UR Medicine telepsychiatry program and has served as an expert advisor on digital health to government departments and organizations across the nation. Ray Dorsey is the David M. Levy Professor of Neurology and Director of the Center for Health and Technology at the University of Rochester. Over the past 10 years, he has been involved with 15 studies involving novel technologies, including wearable sensors, smartphone technology, and telemedicine. Adam Kelly, today's moderator, is currently an Associate Professor of Neurology at URMC and serves as the Director of Teleneurology and Regional Development. He completed a neurology residency and a vascular neurology stroke fellowship, both at Rochester. Before we officially start, we would like to find out a little bit more about you. So please complete the poll on your screen right now to tell us what your experience with telemedicine is. So thank you. It sounds like we have a number of patients and providers and also hospital administrators on the phone. On behalf of the university and really sort of all of us, particularly for those of you who are providing care and administering hospitals and healthcare facilities, thank you. We appreciate you making the time to join us for this. So again, thank you for sharing that information. I would like to turn the program over to our first speaker, Dr. Hasselberg, to discuss the current state of telemedicine at the University of Rochester. Thanks.
Hello, everyone. I want to thank you for having me and having my colleagues, Dr. Dorsey and Dr. Kelly. We're very excited to talk about our experience with telehealth here at the University of Rochester. In a lot of ways, we had expertise in this area pre this COVID outbreak, but we've had a real rapid transition that I'm going to talk about over the last several weeks since the COVID outbreak. Some of the areas that pre-COVID that we had expertise in the telehealth space and was in pediatrics and still in pediatrics for school-based clinics. The work of Dr. Dorsey and Dr. Kelly in neurology and in behavioral health across not only the state of New York, but across the entire country. I'm going to share my screen here. I do have some PowerPoint slides to show folks about some of our experience during the crisis here, the COVID crisis. Can everyone see my screen? I hope so. When COVID broke out in early March, there were really two tall tasks that we had at the medical center. The first tall task was, how are we going to serve our patients when our patients were not able to come in to see us in person? So that was really the first tall task. And the second tall task was, how are we going to readily screen folks for COVID? Not only screen the patients that we see in the community, but also screen our own employees who may be at risk for coming in contact with a patient with COVID in the hospital. So the first thing we did was we needed to come together as a medical center and create almost a command team of how do we rapidly transition from in-person visits over to telehealth visits. Despite, as I said earlier, our expertise in some subgroups like neurology, psychiatry, and pediatrics, pre-COVID, on a daily basis, we were probably doing less than 100 telehealth consults per day. Our overall, on our outpatient side of business, our overall business service line, we averaged about 16,000 or more visits a day in person. So we had a very large volume. As you can imagine, on March 15th, that is really when things hit our community fairly hard. And at that time, the decision was made by our executive leadership to postpone all elective cases that we do. So essentially all non-essential surgeries or elective surgeries and all non-essential primary care visits or other service line visits, we were told to postpone those visits. We quickly needed to shift gears over to telehealth and telemedicine. So as you can see on this graph here, we had a very rapid decline in our service volumes. And this is not unique to the University of Rochester. This happened across the entire country when social distancing started to be enforced, where we were all getting ready for potential surges of COVID and getting our inpatient units set up so we could effectively treat those who were sick. There was a rapid decline in in-person visits across our medical center. We were able to really successfully transition really across the board, all of our departments over to both video consultations and telephone consultations for our patients. And this line that you see here at the bottom of the graph is the uptake that we had in telehealth visits across the medical center. This data is updated as of a couple of days ago. Since the COVID outbreak, we've done over 70,000 telehealth visits. So since this March 15th period of time, and we're averaging a little over 6,000 telehealth visits across our service lines a day at this point. So about 60% of what we're doing at the medical center is now via video consults, while about only 40% is those that we're seeing in person. So again, the second tall task that we had was, how are we going to screen folks that are at risk for COVID? And we all know that there is widespread lack of widespread COVID testing available at this point. And we needed to have a better understanding of who potentially had the virus, both out in the community, but again, also with our employees, so we could have most effectively utilize our resources. So one of the things that we did really early on was the university built an application, a chatbot application that could be used on mobile devices, on computers. And what we did was we put it on our university's external COVID website. And really the initial purpose of this chatbot was to screen out patients who may be worried that they had COVID, but didn't actually have symptoms. So our COVID hotline at the medical center did not become overwhelmed with phone calls. Within the first week, we had about 7,000 individuals across the community who did the chatbot, and our hotline volumes went down about 50%. So that was quite successful. I'm going to show you what you'll see on the screen, a little demo of the chatbot and how it functions. Given our success with the chatbots on our external facing website, we quickly then made it available for our medical center employees. And today, if you're an employee at our medical center, across the board, from our providers, our physician providers, down to our facility staff and transportation staff, if you are going to be in contact with another employee or potentially patients, you need to fill out this chatbot every single day in the morning and before you can come to work. And this data comes back to our employee health to help keep our employees safe and healthy, and also then keep our patients safe and healthy. We're now to a point actually of partnering with Rochester Regional Health System and the Department Counties of Health and Common Ground Health in our community of actually using this technology that we created and to push it out to the entire region, where we're hoping that we can get the community to do this chatbots on a regular basis, so we can have better data around the prevalence of the virus in our region, so we can then help the county make informed decisions about when to start relaxing the social distancing. So we've already started compiling the data and working with the county, and we're really using data to drive our decisions, not only our decisions of where to allocate our telemedicine resources and where to allocate our protective equipment for our employees in the hospital, but we're also sharing this data with the county to help them, again, make their decisions at a county level. Some of this data that you see up the screen here, this is all data coming in from our surrounding counties to the U of R, and we help do some visualizations for the county and serve it back. And this graph here this is our chatbot data. This is our external chatbot data. And as folks fill out this chatbot, we can quickly in real time identify where there are hotspots in our community, and we can identify what specific symptoms are popping up in different zip codes around our region. This will become very powerful when we move with our partnership with our community, including our Rochester Regional Health System, and also potentially working with employers across the entire region of pushing this out. And again, trying to work with our entire community to come together to fill this chatbot out on a regular basis. So again, to inform how we make decisions, how do we allocate resources, and when do we potentially start pulling back on the social distancing so folks can go back to work safely. So in a nutshell, that is the rapid transformation that we've been able to do at the university in a very short period of time. This work has been done by colleagues across multiple departments, and even working with our undergraduate and graduate campus and engineering and computer science and data science faculty to develop these digital tools to support our community. So with that said, I am going to stop sharing my screen and we'll move on to our next presenters. At this time, I want to introduce Dr. Ray Dorsey from Neurology. Dr. Dorsey, are you with us?
Thank you very much for all joining. I want to echo something on Michael Hasselberg. His team at the Health Lab over the last month have developed new tools. Then the absence of diagnostic testing, I think everyone's aware that we don't have widespread diagnostic testing. He has created new tools to map out the symptoms of coronavirus within our community. And he launched this within like a week. He launched this initial chatbot, which is nothing more than a screening tool to identify people with symptoms of coronavirus throughout our region. Our community did that in a week. And now he's doing that for all URMC medical staff and faculty. And then he's going to do it for everyone in the entire community. So that regardless of who you are, where you live, so long as you have one of these devices around, you're going to be able to report your symptoms, map it out, and so we can direct healthcare resources and to people in most need, and enable us to resume many of our activities that we have been prevented from during this period of physical isolation. So just kudos to Michael Hasselberg and his team. So I want to take a step back and say, so what is telemedicine? So telemedicine is nothing more than providing care at a distance. So normally pre-COVID, doctors and patients were co-located in the same point in space at the same time. And telemedicine allows for encounters to occur asynchronously, like this chatbot. People fill out reports and then they can later be connected to care, or synchronous conduct, which is like what we're doing right now. And why is this important? I'm going to try to share my screen. I'm having more technical difficulties than usual, but we'll see if this works. And so hopefully is that working for people? And so you can see telemedicine offers 5 big advantages, and we call them the 5 C's. And the 5 C's are: one, that it reduces the risk of contagion, so that people aren't exposed to the virus, and that means that they don't get sick, and also means that fewer healthcare workers are at risk of getting sick, and other people who are sick within a hospital or medical facility are less likely to get sick. A huge win. Second, it offers expanded access to care. It offers care to people who otherwise wouldn't be able to get care, maybe simply because of where they live. Third, it offers increased convenience. You don't have to travel to the clinic, and you don't have to park in a parking lot, and you don't have to wait in a waiting room. Fourth, it offers enhanced comfort. You get the care that you want in your home without ever having to leave it. You're on equal footing, far more equal footing with your clinicians than you would be in a clinic. And also it offers greater confidentiality. We see this for people who are at genetic risk for certain disorders, and they don't want people to know about that genetic risk. We also see that a lot in mental health, where people want to, have privacy regarding their needs to see a counselor or seek help for a psychiatric condition. So that's why telehealth, and I'll stop sharing. And then the question is so why hasn't this been going on? Why did we have less than 1,000 visits a day? Less than 1,000 visits, probably less than 100 visits a day in the medical center. And now we have 60% of our visits being occurred via telemedicine. And because we had substantial barriers to the use, and the biggest barriers were around reimbursement and secondary licensure. Prior to COVID, especially for Medicare, I care for people with Parkinson's disease. Medicare didn't pay for telemedicine, paid less than 0.1% of its budget on telemedicine, didn't provide for telemedicine unless you lived in a health professional shortage area and you had to be in a clinical setting. So you couldn't even get telemedicine in the home. In fact, before COVID, Medicare paid $200 for a patient to come see us at the University of Rochester, $100 for us to see a patient in a clinic near their home, and $0 to be seen in their home by a specialist. In the setting of COVID, the Center for Medicare and Medicaid Services has waived that and is now reimbursing for telemedicine visits into the home. Second big thing is around licensure. Historically, the care you've been receiving, patients can only receive care from clinicians licensed in the state in which they reside. Not a huge deal in New York and Rochester, but if you live in New Jersey and you went across the Hudson River to see a clinician at Columbia University and you went back to New Jersey, that Columbia University doctor licensed in New York could not see you in New Jersey because they weren't licensed in New Jersey. Those have been waived, and they've all been done so temporarily. Next is that all these changes are temporary, so we need to make sure that they become permanent so people can realize the care, convenience, comfort, and confidentiality of telemedicine even after the fact. Two last comments. One, we are in the midst of the greatest transformation of healthcare practice ever. We are in the midst of the greatest transformation of healthcare practice ever. Michael just showed you that we went from having less than 100 visits a day via telemedicine as a medical center to having 60% of our visits via telemedicine. That's all occurred in the span of like 4 weeks. We've seen a 100-fold increase in adoption of telemedicine in weeks across almost every major medical center throughout the United States. It is unprecedented. Some people said we've seen a decade of change in 3 weeks. We've seen a century of change in 3 weeks. And it's likely that some of this is going to be permanent. So I'm going to take a chance here and see if I can go to the whiteboard and draw something out for you. So what's the future look like? So right now, if you're a patient, you go see a doctor, or you go see a nurse, or you go see a physical therapist if you tore your ACL, or you might go see a nutritionist. And all these things generate a lot of revenue for the medical center, because they're paid well, and that's what the incentives, financial incentives in front of the medical center. What's going to happen in the future is a radical transformation. One, all these arrowheads are going to go the other way. So no longer are you going to go see the doctor's going to see you. No longer are you going to the nurse is going to see you. No longer are you going to the physical therapist is going to see you. And no longer are you going to see nutritionists, they're all going to see you. They're going to see you either remotely or they're coming to your home, because you're not going to go to see them. The other thing is that payment for these visits isn't going to be lucrative. It's going to be about half what it is today. So we're going to see a transformation in the way healthcare is delivered and the way healthcare is paid. So these changes, these two changes, how it's delivered and how it's paid, have enormous consequences for medical centers. As most people know, medical centers across the country are losing $2 to $8 million a day. It's no different than it is here at the University of Rochester. The Mayo Clinic has already announced furloughs. So we are in the midst of a radical transformation of healthcare that's going to be very painful financially in the short term and near term, but I think have potentially enormous benefits for the way we reconceive medical care. I'll stop there.
All right. Well, thanks, Ray. Michael, why don't you go ahead and start your video back up again, and let's go ahead and get started with our Q&A session here. I want to thank everybody who had either submitted questions ahead of time or has been submitting questions through the Q&A function on the Zoom meeting. We'll try to get to as many as we can, but we've had a really overwhelming response to that. So if we don't get to your questions, I apologize for that. We'll definitely try to group some recurring themes together, you know, to try to hit on a lot of different questions that came in from multiple people. And I actually want to start first with a question more from the patient or consumer end of this. I think, you know, we saw in the poll at the very beginning, actually more people who are on the session today are not healthcare providers, you know, or really directly on the provider side of things. We're going to be more on the patient side of things. So, you know, for Michael and Ray, what would you tell a patient to expect, you know, to be different in a telemedicine encounter versus a traditional face-to-face encounter? And we had, you know, some questions come in about what people can do to better prepare themselves as a patient to really enhance a telehealth experience as opposed to a face-to-face experience.
Michael, you want to go?
Sure. That's a great question. So for the specific telemedicine work that I do as a provider in behavioral health, what I tell patients is expect what you would expect in a face-to-face appointment. That I'm going to do the same evaluation, the same assessment. Just the medium that we're going to do it is, you know, via video versus you sitting right there with me in my office. The same expectations is on both the provider and the patient in regards to what you would expect in a face-to-face appointment. We expect the same thing in a video conferencing telemedicine session. So as a provider, I make sure that I am in a confidential, secure room. I'm professionally dressed. I'm not doing it in my pajamas. You know, and I'm asking the patient to also, on the other end, be in a place not at Starbucks or, you know, out in the community, but in a place that's private. And also have the same professional etiquette that they would bring to a face-to-face appointment, right?
Honestly, it's not much different. If you can use Zoom, you're good. It's good so that you can have a place to, you know, walk and around so that the doctor wants to see you walk or do things. But the vast majority of people can adopt this approach. And, you know, 70% of the people who've done telemedicine have done it in the setting of COVID, so they can tell you what their experience has been.
Yeah, I think, you know, I'll just chime in too. I think, you know, some of it too is just being prepared, you know, just like you would in a, you know, when you go to a visit with a provider in a face-to-face encounter, you bring a medication list, and, you know, you should have your medications handy for a visit like this, even though they might really be on your shelf. You know, I think just to make the visit run as smoothly as possible, it's great to have them, you know, right there with you. I think that goes on the part of the provider end too. If you know you're looking at someone who has a knee problem, you know, make sure you ask the patient ahead of time to, you know, wear shorts or do something that will really facilitate that visit, so that in the middle of the visit, you're not saying, okay, well, let's have you get changed and, you know, have you undress in the middle of a video. So, you know, I think this is a, you know, principle where being prepared can go a long way. A couple questions we got were related to security and confidentiality of using, this. And, there have been, reports out in the media about, privacy or security issues related to different video platforms. Ray, I know you said that confidentiality was one of your 5 C's, which, I think in some sense it is, but there is a lot of concern, I think, out there on the public's behalf about security and confidentiality. And so, maybe, you could start first with this question and just, give your thoughts about the security of platforms that we use and, how you address this if patients have concerns.
I think for the most part, it's overblown. I only see patients over the internet for the last 7 years. I've been doing it for 13 years. I haven't had a confidentiality concern or privacy breach to my knowledge. Not to say that it can't happen. I'm sure it can. I'm sure more people have had their confidentiality compromised by coming to clinic and letting people know that they're going to see a neurologist than they've ever had by seeing me remotely.
Michael, what do you think? I mean, you're in a mental health space, which, is maybe a little bit more of a hot button issue for certain people. So what's your approach to that?
Yeah, I can echo Ray. I have not seen a patient in person in over 4 years, and I've been, seeing patients via telehealth exclusively over the last several years, and have not had a breach myself. That being said, at the University of Rochester, our video conferencing platform runs off of our secured servers at the university, and there's a whole privacy and compliance team with our IT folks, and they take it very seriously to make sure that the video conference is encrypted and secure. But during this COVID crisis, there has been some relaxation on the HIPAA requirements from the federal level. So platforms that typically we didn't think were not secure, maybe like FaceTime or Skype or other platforms that folks may be more familiar with on a consumer basis. There are health systems that are using those platforms. Our health system has specifically elected to not use those platforms for telehealth visits, and we use the platform that our IT feels comfortable with that we were using pre-COVID.
And there are going to be bad actors out there, and there should just be high punishments for the bad actors.
Yeah. So along those lines, Michael, you just brought it up. That right now, non-HIPAA secure forms of communication, whether they be FaceTime or Skype, or other things are being used. They're not being used here at the U of R. But what advice would you give to a consumer, who was seeing a provider who wanted to use one of these, potentially less or non-secure, less secure platforms? Would that be something you would advise against, or?
Ray, do you want to?
I think it just matters. You've got a sprained ankle. I don't think anyone really cares, about it. If you're doing, talking about reproduction or sexually transmitted diseases, or you're talking about some mental health issues, I think I would opt for a secure one. I think the big issue for most people is getting access to care, not the security of the transmission. It's good that we can do it. We're doing Zoom. We're doing this right now, though you can even see the green lock in the upper left-hand corners indicating that this is secure. I just don't think it's a huge issue for most cases.
Yeah, and I would just, as a consumer, do my due diligence of who's the provider on the other end, or the organization that is providing the telemedicine visit. And if it's a reputable, well-known provider that you trust, or an organization that you trust, I can guarantee you that they are just as worried as the consumer about making sure that that visit is confidential and as secure as possible. So I would do my homework on who is the person or the organization on the other end versus the actual technology that's making the connection.
Right. Those are great points. And again, I think, as Ray pointed out, I think a lot of this too is, we think about the downside potentially, which is a legitimate concern, but the upside in terms of access, especially where, we've effectively, stopped a lot of face-to-face visits. And in fact, there's other communities, where COVID is much more, rampant or prevalent, where it's even more dire in terms of the struggle in seeing people face-to-face. So that, we have to trade some risks with, I think, those, upsides of still maintaining access. So I also want to reassure the audience, we have two people here who don't see people in person. Some of us physicians actually still do see people in person. I do a fair amount of teleneurology and telestroke work, but some of us actually do see people in person still. So, we had a lot of questions come in, related to what can and can't be done in a telemedicine visit. So, obviously, our examination is a little different since we can't, in the traditional healing sense, lay hands on patients. Can either of you comment, on, how you maybe modify what you do in terms of your examination, to make up for the lack of a face-to-face encounter? And, maybe Ray, I'll put you on the spot with this specific question. There's questions about things like, peripheral devices, like ways to listen to, heart or lungs, or, even in the spirit of COVID and flu-like infections, like looking at the back of the throat. I mean, do we have ways that we can, really tailor our examination to get the amount of information that we need?
Short answer is yes. There are lots of peripheral devices. Lots of our colleagues in cardiology have these, remote stethoscopes, remote ultrasounds. Obviously, people have blood pressure cuffs. People have devices in their home. I saw a question from Welsh Allen. Some of these devices are enabled for mobile use. But I think it's worth noting two things. One, the setting of COVID, most people are being seen in the home, so those devices aren't there, although some people do have blood pressure cuffs and scales. And some things people just do. I mean, the sore throat, they just literally say "ah" in front of the camera and go up close to it. You have your phone, you can take a picture of your rash, you can use your light, you can do lots of creative things just with the existing technology. Step back, 80% of diagnoses are based on history. 80% of diagnoses are based on history, 10% on exam, 10% on laboratory or imaging modalities. So the vast majority, but not all care can be provided remotely. We have some surgeons who are probably listening, an acute abdomen, if someone's got a tense abdomen, really difficult to assess that remotely. And some of that you just have to say you have to come in to be seen. And, Adam's shaking his head because sometimes telestroke, it gets really, really complicated and you can't figure it out remotely and you got to come in. Even in my world in Parkinson's disease, sometimes people don't just have the classic rest tremor and they have other symptoms I can't figure out, so that comes in. But that's less than 5 to 10% of cases. So short answer, yes, there are peripheral devices. Most of them aren't necessary, but some can be used, especially for certain specialties. And you always have the option, almost always have the option to bring somebody in.
Michael, you have anything else you want to add to that, or?
Listen, as a behavioral health provider, I'm not the guy you want laying hands on you and doing a physical assessment. So for our needs, we can do really everything that we can do in person. We can do via tele in the behavioral health space. And again, my subspecialty area is geriatric psychiatry. And so even with the older adult population, I can do a neuro exam virtually with a patient. I can do neuropsych testing with a patient virtually. So in the world that I work in, this modality is actually perfect for us.
Right. So that's a great segue because, we just got a couple questions related to, working with patient populations that maybe aren't the traditional tech savvy populations. I mean, I'm kind of using a little bit of a stereotype here, but, whether they be older adults or, Ray and I both see neurology patients who may have neurologic disability that can affect their ability to, connect via technology. So, I mean, do you guys think, again, I think Ray already mentioned that one, some of the myths about telemedicine are a little bit overblown. I think people feel like, maybe at first pass telemedicine is something that applies to a younger population who's, used to being on whatever app is hot these days, TikTok or, Snapchat or whatever. What's been your experience, again, Michael, with, primarily working with older adults? I mean, do you feel like this is something they're able to pick up?
Absolutely. You know, it's interesting. When you look at the baby boomer generation that is, you know, aging into the older adult or older adult population. This is a generation that's extremely tech savvy. I mean, they were around. You know, when computer programming first, you know, started and the home computer and cell phone devices, and had to quickly adapt and are very comfortable with technology. And that's what we found. It's interesting when you talk about apps, mobile apps, and some of these telehealth companies that work through mobile apps. We did a focus group study getting prepared for developing a mobile app specifically for Alzheimer's disease. And I had some students, you know, in their mid-20s, psychology fellows and interns who ran these focus groups with older adults, 65 and older, around mobile app use. And the results that we got back was the older adults that we had in these focus groups were using more mobile apps than my 25-year-old to 27-year-old psychology intern or fellow. So I definitely think it's a myth that that the majority of the older adult population are not tech savvy. Ray, your experience?
So yes, I think all three of us skew toward taking care of really old patients. You know, the oldest we've done is 92. But there's something called the digital divide. So there's a lot of people who are left out. So, you know, I said anyone who has one of these devices, but, you know, 20% of Americans don't have one of these devices. 20% of Americans don't have home broadband. These individuals tend to be older, tend to live in rural areas, tend to be minorities. A lot of our telemedicine projects have overcome geographic barriers to care, but have really struggled to address social barriers to care. So this digital divide is a huge issue. It can exacerbate inequities. Our challenge is to find ways to use these technologies. Michael's chatbots, one good example, we're spending a lot of time sweating this, is how do we get this to the people who need it the most, and not just the people who are most tech savvy.
Yeah, I think, you know, that's a great point, and something we're, you know, I can say as our telehealth, you know, outpatient work has really ramped up. So I think we're very sensitive to that. That, you know, are we really kind of catering our services to, you know, a specific, you know, population, you know, and not reaching certain, you know, groups, as Ray mentioned. You know, the other thing on the flip side, you know, we have people who have transportation issues, and, you know, sometimes it's easier for them to connect with a physician via, you know, their smartphone than it is to get on 2 buses to, you know, get to the medical center or someplace else. So, you know, hopefully we can find, you know, a telemedicine approach that's, you know, that's broad and really, you know, captures all of the people who we need to reach. So, you know, Ray, I know you brought this question on a webinar I saw, you know, a couple, like maybe a week or so ago, that, you know, Rochester, as you pointed out, is the home of the biopsychosocial model. And, you know, inherent in that is building a really strong, you know, relationship between a provider and their patient. And, you know, what's been your experience in, you know, how you build rapport, you know, with patients through a video interface as opposed to a traditional face-to-face encounter? Because I think that's, again, you know, one of the potential, I guess, you know, mental barriers that people have to, you know, to seeing a physician, especially, or provider, especially someone who maybe they haven't met before.
So I think there's something fundamentally powerful about a clinician seeing a patient on their terms. Mm-hmm. If you think about it, we ask sick patients to see us, generally healthy clinicians, on our terms. And it's just like, it's a non sequitur. We should be seeing patients on their terms. And there's something very powerful when you do that. You bring the care to them on their terms. They're in their home. They're dressed in how they want to be dressed. And also you get more, what you lose in an exam, which we talked about, you more than gain up on social history. So, you know, I can see, you know, you like to read. And Michael's got like a big room back there, and I'm not exactly sure what he's doing. He's got a couch. He's ready for a psychiatric evaluation. But you get to see people in their natural setting. You can see them with or without family members, with or without friends, pets, not pets, various stages of dress and undress. I get a lot more insight into their economic and social situation than you would. We did a national randomized controlled trial where we compared usual care to usual care plus video visits. And people actually said most people said they had more of a personal connection with their virtual doctor at the end of a year than they did with their in-person doctor. Not everyone, but a lot of people said they had better relationship, better personal connection to the virtual doctor that they've never met before. So I think there's something profoundly powerful about this, and that's why I've been spending a lot of time on it.
Michael, what's your experience been there?
Yeah, in behavioral health, there was, I have colleagues that, this is not going to work with my patients. What we do is we build therapeutic rapports with patients, and we need to see them in the office. And consistently across our department, what we've learned during this COVID in our department, we're almost up to 90% of everything that's happening in our department now post-COVID is all video consults. And our volumes have gone up, where most departments, their volumes have gone down substantially. We've had an uptick in our volumes. And what I'm consistently hearing back from my colleagues who have shifted over to video consults is they're hearing from their patients, that they actually are more open with them. And they're telling our psychiatrists and psychologists and therapists things that they may have not felt comfortable telling seeing the psychiatrist in their office. When I see my older adult patients in nursing homes, they're taking the iPad on the other end and showing me the pictures of their grandchildren on the wall and, showing off the room that they're in. And like Ray said, I'm gathering a lot of social history that helps my evaluation, seeing that patient in their own environment.
Yeah, and I think too, we've seen a bit of a change too. I think historically, we thought about, the paradigm being that you needed to see a patient in person and then decide, okay, in the future, I can probably see you via telemedicine. And, now maybe it's the other way around. Maybe we can start to be seeing more people via telemedicine. And then, based on what you're able to do via your history and your examination, through a televisit, then you can say, look, I don't like what I'm hearing. I don't like what I'm seeing now. Actually, I do need to see you in person, as opposed to kind of, the other way around. So it'll be interesting to see, how that kind of changes the breakdown of who we see, in person via telemedicine in the future. I wanted to ask you guys a little bit about team-based care. I mean, we increasingly, I think Ray drew the diagram about, the different types of health professionals that a patient may see. And in a lot of settings, we try to deliver that simultaneously in like a multidisciplinary clinic where, at the same visit, we have someone see a provider, we have them see a nurse, we have them see a pharmacist, we have them see a social worker, we have them see various therapists. That's one of the, to me, one of the real powers of telemedicine is that you can put everyone into kind of a virtual examination room or a virtual meeting room like we are doing here. So maybe if you guys have any experience doing that, what your experiences have been, and, is that something we can hopefully continue to do in the future?
You want to go, Michael?
Yeah, interestingly, we started that before we started actually just seeing provider to one patient on the other end. So we've got a lot of experience in team-based care through a telementoring model called Project Echo, where you actually have a multidisciplinary team of specialists at the medical center who discuss patient cases and provide, best practices. And then again, in our department, even things like our partial hospitalization. So a level of care where the patient doesn't meet criteria for being in the hospital, but really doesn't meet, they need more care than just seeing an outpatient psychiatrist. We have a partial hospitalization program. So all the benefits of being in the hospital, but you get to go home at night. We've transitioned that program all the way over to just video consultations. And as you can imagine, in a partial hospitalization program, you have multiple disciplines. And so we hold group psychotherapy sessions where, you've got multiple different disciplines and providers with actually multiple different patients in a secured meeting together. So a lot of success with team-based care.
I would just say that the status quo, what was prior to COVID, is dead. You couldn't think of things much worse than asking someone to interact with 5 different clinicians in physical proximity to one another, and getting those people co-located in space and time is just difficult. Now, I think you're going to see more people get the physical therapy they need. They're going to get more psychological care. I mean, Michael's already indicating that telemedicine is allowing greater access to mental health. I mean, across the country, mental health care is scarce, and now we can increase its accessibility and its confidentiality and reduce its stigma. I think we're just need to be prepared for a vastly different world. One of the questions is what's going to play out in the next 5-10 years. I think it's going to play out in the next 5 weeks. Is that we're going to have vastly different ways of delivering care. People are going to get nutritionists and occupational therapists. I mean, think about kids with autism. I mean, what parent doesn't want their kid to get occupational therapy 3 times a week? Bringing an autistic kid to a clinic to do that? Impossible. Getting an occupational therapist to see a kid with autism in their home 3 times a week remotely, entirely possible. The sooner we reimagine the future, the sooner we see it, the sooner we can act on it, and the sooner we can lay the foundation for a vastly improved way of delivering healthcare, and one that's going to be more sustainable than the one we currently live in right now.
Yes, that's a great question. And so just to follow up on that, so as you mentioned, a lot of changes, a lot of lightening of regulations and things that have allowed this rapid uptick in telehealth to happen, are temporary, and what temporary is, I think is unclear at this point, because of what will happen with the pandemic and, how long will the public health emergency that's been declared that allows some of this to happen, how long that will stay in place, even if infection rates decline. Who ultimately will drive a meaningful and persistent change in this space? Will it be patients and patient advocates? Will it be medical providers like us? Will it be, healthcare organizations who basically say we need less space. We can save money by doing things this way. I mean, is it, realistically, it will probably be all of those things to some degree. But I guess, Ray, for you, what do you think who do you think, or what do you think will be the ultimate driver of meaningful, persistent change?
Well, it won't be neurologists. It's a political question. To make many of these changes permanent will require congressional action, especially on the Medicare front, and that will reflect interest from hospitals and medical centers, some of whom would like to go back to the ex ante, to what was before. I don't see as that, because it's more economically sustainable and lucrative, quite frankly. I'm not so sure that that's going to be possible. I think you're going to see widespread pressure on Medicare and Medicaid to reduce costs. One of my colleagues said the number of Medicaid beneficiaries is practically go from 70 million to 100 million. Take them together with 50 million Medicare beneficiaries. So that means 1 out of every 2 Americans is going to be insured by a public insurance program. And states are going to have limited resources, and the federal government's going to have limited resources. So I think these are going to be political questions. I think we will see some of these telemedicine changes made permanent, especially around the reimbursement front. I think patients are going to, every telemedicine study shows enormous patient satisfaction. And so if we get millions of people, and the longer this goes on, millions more will get experience with telemedicine, and they won't really want to go back to the parking lot and the waiting room. So I think these will be adopted. They'll have enormous financial adverse consequences in the short term for medical centers, but in the long term have the chance to redefine how we deliver care and make care more accessible, and I think fundamentally improve medicine.
And Michael, you have any comments on that, or?
That was well said. To me, it's going to be the consumers that are going to drive the change. I think consumers are just going to demand a more convenient, more accessible, high quality, and lower cost care, and digital health can provide that. And this, to me, is just going to be the new norm. And at the same time, what our models show is, the COVID virus is not going away anytime soon. And so bringing potentially at-risk patients with COVID into the hospital where we have other at-risk patients is probably not a good idea. So I think that digital health is not going away anytime soon. I think consumers are going to demand the change.
Yeah, I agree. I think, people I think people, especially if this is going to take congressional action, I mean, that takes voters, which, takes a lot more than just, the three of us, but we do have a lot of participants on who maybe can help with that. The other thing I would add to that is, what we're really looking for from a healthcare perspective is value, which is, better outcomes over, less cost. And I think, one thing we're starting to think about too is, Michael showed the slide of the quantity of visits of going up, but it's hard to always kind of wrap your hands around what constitutes a quality, a quality visit. And, one thing we look at is like decreased utilization of tests or ED visits, but right now people are avoiding those for other reasons because of fear of infection. So, we'll have to kind of get to a steady state where we really, I think, approach the quality side of this as well. So, I think we've just got like a couple minutes left for some closing comments. I'm going to ask both of you to kind of weigh in on this, I guess, as your closing comment is that, Rochester, I think, is already, pretty well positioned as a leader in the telemedicine, telehealth space, largely because of the work of, you guys and other people here in Rochester. So, what else do we need to do? How else can, we really put U of R on the map as, the place for telemedicine? If there's like one or two things on each of your ask lists, what would that be? I mean, Michael, maybe I'll start with you.
Putting the pressure on. I think getting the word out in our community. University of Rochester is, we're a well-known academic medical center. Ray is an unbelievable researcher. And so we disseminate our great work through research articles and presenting at conferences. And so I do feel that we have national visibility, but our community knowing that, hey, the University of Rochester is the gold standard for delivering high quality healthcare at low cost, conveniently using technology. And, just getting that word out across our community would be my big ask. Ray?
I think we're in the midst of the greatest existential threat to universities and medical centers ever. We are in the midst of the greatest existential threat to medical centers and universities ever. No organization, not even ones with large endowments, can go on losing $2 to $8 million a day. It just can't be done. So I think universities and medical centers that rapidly envision what the new future is going to be like, and it's not going to be like the past. We're not going to put 400 people into a chemistry lecture hall. We're not going to bring people in for multidisciplinary in-person care. Patients are going to want to limit exposure to healthcare workers. Those organizations, medical centers, and universities that envision the future most creatively and fastest have a lot to be had. It's soon going to be nice in Rochester. The temperature will be above 40 degrees. Shouldn't we be doing outdoor classrooms, and shouldn't we be doing outdoor visits with patients? Shouldn't we be enabling anyone anywhere to be able to see a University of Rochester physician or mental health professional or neurologist or occupational therapist or nutritionist? Shouldn't we be able to provide immense and high quality, large number of visits to people wherever they are, however they live, on their terms? I just think there's an entirely new future out there. The sooner we recognize that there is a new future, the sooner we embrace that new future, the sooner we create that new future, the better we'll be, both in the short term and in the long term.
Yeah, I mean, I would second that, completely. I mean, both of what you said, but, I think, just dovetailing particularly on what Ray just said. I mean, I think the concept of medicine of the highest order, I think extending that, to, people who maybe have access issues and I'm a small town kid from upstate New York, and, just, seeing like the struggles that my parents and my relatives have accessing medical care. I think we have a real opportunity to make sure that our entire community, our entire region, gets the care that they need, because we've now created an environment where, they can get it much easier than they would have. And, the coronavirus has been, devastating in many ways. It's been tragic in many ways. If there's any kind of silver lining, it's if we can really transform what we do to enhance healthcare in the long term, I think, we're obligated from the medical center to grab that opportunity when we can. So
there are lots of silver linings. We can reconceptualize work, we can reconceptualize education, we can reconceptualize healthcare. We have blank slates on which to sketch out the entire future, and that's what we should be doing. That's our mission: learn, discover, heal, and create, and to do it ever better. And that's exactly what we should be doing.
Great. Well, I think we're actually doing really well on time, so I'm going to consider that. I mean, a positive outcome from this too. So I just want to thank Michael and Ray for a really great presentation. I hope that people really enjoyed this. I want to thank everybody for joining us on what was the first Experience Rochester virtual program. So we were, a bit of a guinea pig of sorts here, but I think things went off quite well. We hope you enjoyed. We're anxious to get your feedback. So, when the session is over, there is going to be a brief anonymous survey that's going to show up when the webinar ends. So please take advantage of that if you can. And then please also join us next week. So on Thursday, April 30th at 1 o'clock, the next Experience Rochester lecture is going to be featuring Professor David Primo, and his talk is going to be entitled, Will American Democracy Survive COVID-19? With that, I'm going to close, and I wish everyone a great afternoon, and I hope everyone stays well. Thank you.